if I can just start with that first point around classification, do you think the UK model is currently fit for purpose? Professor Nutt, if I start with you.
Well, I think it's very clear it's not. And you heard in your last set of evidence that it's actually deaths from drugs are going up and the use of drugs are going up, and that's happened ever since really the Misuse of Drugs Act was started in 71. So, 50 years on, we've shown it's pretty clear that it's really not achieved its purpose. And one of the reasons it hasn't done that what it was supposed to do is because it isn't based on evidence. The classification of drugs under the Misuse of Drugs Act has zero correlation with the harms of drugs. And that presents major problems. It presents problems in education. Telling people about drug harms is almost an irrelevance if you use the Misuse of Drugs Act, because people know it's not evidence-based. And of course it drives policies which, as you heard again last week, can be counterproductive. So you can, by trying to stop people using cannabis, you end up killing people because they move to a drug like spice. So it's at many levels it's failed.
Thank you. I'll come back to you, but I'd just like to take other views from panellists. So Professor Corazza.
I would like to refer to the context in which especially the Psychoactive Substances Act was actually implemented. I think it's very important to go back to that specific moment in time, because the situation, the phenomenon, the rapid emergence of hundreds of novel psychoactive substances really challenge regulatory system nationally and internationally. Let's admit it, at that time we were all unprepared, and we try often to apply old models to a completely new situations. So far, we know that over 1,000 novel psychoactive substances have emerged in the illicit market, according to early warning system of the United Nations and the European Commission, the MCDDA, in over 133 countries. So it's a widespread and global phenomenon. Is driven indeed by globalization, but also by the internet and the technological development, but also the changing lifestyles in our society. Because the drug market is a dynamic market, it's constantly changing. So in a way, we try to apply old methods to a completely new situations. I remember at the time I had school teachers phoning at the university and telling me we got bags of white powder coming into into the schools. What shall we do? Is it legal, not legal? We had head shops, if you remember, selling all these drugs that we well know as a legal alternative to illicit drugs. We never seen anything like that before. So at that time, the government did a response based on a situation of emergency. But since then, a lot of things have changed in terms of drug market. I'm mainly looking at new novel trends. That's mainly my work. And I would like to share possibly with you some highlights of the work that is emerging. So,
Could I just stop you there, because we are going to have a section where we'd like to discuss the psychoactive legislation that we've got in this country.
Later.
So I think we will come to that if that's okay.
Yeah, and thank you. If I just move to Professor Neill, just to take your view on this as well.
Thank you very much. Yes, I completely agree with everything that Professor Nutt said. The classification system it's not based on evidence. And it's clearly not fit for purpose. I mean, my main interest is in drugs that are currently illegal, like psilocybin is the active ingredient of magic mushrooms, a so-called psychedelic, that has enormous therapeutic potential. And that is a Class A drug, and it is also a Schedule I drug. I'm hoping I can talk about the barriers to research and to innovation caused by these drugs being in Schedule 1. That's a specific topic I would like to cover if that's planned today. But that does exemplify that the current scheduling system is incorrect, because the definition of Schedule 1 is that a drug has no medicinal value and that it causes a great deal of harm. And psilocybin does none of those things. It has medicinal value, and it does not cause significant harm.
Thank you. We'll come on to some of those specifics later in the panel. Professor Reece, I realise you're sat in Australia, but I just wonder if you've got a view on the UK classification framework.
Yes, I do, sir. My view would differ from some of the other panellists that you've heard. I think that the current system is probably a good one. I am particularly concerned about cannabis, as you would have noticed from my submissions to the committee. And cannabis is very important because it's well established to be a gateway drug to other drugs. And one of the most prominent features, the whole pharmacology and toxicology research literature on cannabis, is its exponential dose response effects. It has exponential dose response effects. And in the society which we all live in now, and this is a global feature, I mean, the details are different in Europe, America, and Australia, but it's generally true that there are three changes that have happened in many places in the world. There are more people smoking weed due to the legalization movement. There is more people smoking weed daily. The intensity has gone up. In the US, it's gone up 2.1-fold in the last 12 years. And the concentration, the THC concentration, in fact, the concentration of a lot of cannabinoids has gone up enormously, as is well established. Now, the point is you have three trends. You have a higher prevalence of use, a higher intensity of use, and a higher cannabinoid concentration, all acting at the same time. The point is that the community is being relatively suddenly springboard catapulted up into the high genotoxic dose zone. And the genotoxicity of cannabis is virtually never discussed in public. It's a huge issue. It affects brain development, it affects the development of every organ system in the body, and it's linked with numerous cancers, as our recent papers show. So the magic which the current regulatory system has done is to confine the community to a relatively low dose of cannabis use. We know that everywhere cannabis legalization is rolled out, including Colorado, and there's a long list, but I won't bore the committee with that, literally the wheels fall off. I'm not sure if the committee is familiar with the recent statistics coming out of Colorado. On every index, they are horrific. So by confining the community to a relatively low dose area of use, it's protected community from numerous harms which are directly related to cannabis pharmacology. So we think the current regulatory system, which is relatively tight compared to what's being proposed, is relatively successful, except that, this is a big exception, in our view, massive community education needs to occur so that everybody's on the same page about the risks. Because right now there's a lot of talk, which is mostly hypothetical, and there's very few randomized controlled trials, which is the clinical gold standard, I'm sure you all know, for cannabis or the other illicits. And a lot of the established harms of these things are well established. And right now, the general discussion has got way out of kilter in terms of overemphasizing these hypothetical, perhaps, benefits and underemphasizing the known risks, especially in the case of cannabis, the genotoxicity, the exponential effect, and the fact that it applies to many of the common cannabinoids.
Thank you. And if I can stop you there, because we're going to be coming back onto this topic later, and I'm sure you'll have a lot to say on it. Just for those who, the majority who have issues with the current model, I'm curious to hear what you think would work. So is there anywhere around the world where they have a classification model that is responsive, is evidence-based, is dynamic, where we should be looking to either emulate or take the best from? Professor Nutt, if I come to you.
Well, yes. I mean, there's two separate aspects to this. So you can achieve, I think, important goals by changing the way you enforce prohibition on drugs. So the most obvious example is decriminalisation, which is shown to be really quite effective in countries like with cannabis in the Netherlands. It actually reduced the gateway effect that cannabis might have had, which of course is not actually due to the drug, but is due to the way you get the drug from, and the fact that to get cannabis you're almost always dealing with a dealer who will offer you other drugs. You've got Portugal, where we've seen essentially removing drug users out of the criminal system and putting them into the health system has dramatically reduced the deaths from opiates. whereas in the UK, they've reduced their deaths by 2/3 in the last 15 years. Ours have increased by 2/3 in the last 15 years. And you've got countries now beginning to open up the utility or change their regulations so that it's easier to study these drugs. And as Joe Neill said, there's remarkable evidence developing on the clinical utility. And my own view, and I'm one of the leaders researching in this field, is that the last 50 years it's been the worst censorship of clinical research in the history of the world. The opportunities we've lost in the last 50 years by essentially not allowing proper studies on cannabis, making it very, very difficult to study psychedelics like psilocybin and MDMA. That's actually been the wasted opportunities are vast. So we should be changing the regulatory system to make it more honest, or the classification system to make it more evidence-based. But the regulatory controls, I think those are the things we really should be focusing on, because it would be quite easy, as Rudy Fortson said at your last hearing, it's much easier to change the regulations to facilitate at least the medical profession having proper access to these.
Can I ask, just to follow up on that, because you paid a political price over the years for speaking up on this. What's lacking in our country to stop us making that decision? Is it political will? What was the framework if we pick on Portugal, for instance, that allowed them to move to the model that they've got now?
Well, it's interesting. If you look at Portugal, in many ways the main driver was economic. Because there comes a point, and we've seen it's not just in many countries which enforce regulation, try to stop drug use through criminalisation of people. That's very, very expensive. I mean, I think in this country we have doubled our prison population in the last 40 years, and that's all due to drug crime. You can work it out. So that's billions and billions of pounds that have been wasted by putting people with drug problems in prison when they should have been treated outside. So the Portuguese movement was really driven to try to reduce this enormous cost of policing, and it's been very successful. Moving drug users from the criminal justice system into the health system means some very fundamental changes occur. So, for instance, they don't have to commit crime to get their drug because it gets prescribed, or they get into treatments where they don't use it at all. And that dramatically reduces the costs of the criminal justice system. It improves outcomes. It reduces the sort of the collateral damage from drugs, like with things like HIV and AIDS. And that. So we've there are clear examples of how you can get enormous social as well and economic benefits from a more rational policy.
Thank you very much. I'll hand back to you.
Thank you. We're now going to move to Carolyn Harris, who I think is going to ask about the psychoactive substances that the Professor started to talk about.
I take you back to the 2016 Psychoactive Substance Act, and we'll all have memories of seeing young people and videos of young people behaving in very strange and upsetting scenes. And it was at the time they were known as legal highs. Not something I ever thought should be legal. Has the Act actually reduced the number of people who are affected by psychoactive substances?
I doubt it. I mean, I don't think there's any good evidence that it has. What it's done is driven the purchase of these drugs from head shops. The Act was driven to get rid of head shops, really. I don't think anyone thought it would stop the use of recreational drugs. It did. I think 50% or more of head shops were closed down. But the sale of these drugs continues on the black market. It continues in the back streets. And that's the worst place of all, as we know, because the dealers don't really care about the life quality of the people they buy from, whereas head shops are actually often run by people that use these drugs and at least give people some direction. And certainly we've seen in the 6 years now from the Act, we haven't seen a massive diminution in the use of synthetic cannabinoids or spice, and we've seen still some very, very toxic ones coming along. So I don't think there's any good evidence it's helped at all. But Ornella may have a different view.
Yeah, I would like to build on that. Yes, it was successful in terms of stopping the open sale. of NPS, novel psychoactive substances at the time. Most of the head shop closed down overnight, I remember, when it was implemented. The number of substances, novel psychoactive substances generally dropped in the past few years. But of course, novel psychoactive substances are still a big challenge at the moment, and we need really to face new challenges in terms of the detection and monitoring of the new substances coming out. They are more and more toxic, understanding patterns of use, but also developing new and more appropriate public health approaches. In particular, I would like to refer to our study on the diffusion of drugs on the internet. While we've seen a decline of number of substances advertised on the open web, we've seen an exponential increase of substances advertised and sold on what we call the darknet. So what we see normally on Google is less than 1% of all the amount of information and activities going on online. So we are looking on a deeper level of the internet, where the market of illicit substances is predominant. According to recent MCDDA and Interpol report, the number of transactions have tripled in the past 3 years. And 2/3 of the products offered on the darknet are drugs. We also know that sellers are mainly from the United Kingdom, the Netherlands, and Germany. So we play a big part into these criminal activities. And at the moment, according to a report by the United Nations, there are more than 95,000 drugs available for sale on the darknet. As you might know, payment on the darknet happens with cryptocurrency, so it's extremely hard to detect the transaction, and communication is anonymous, so it's extremely hard for us to study, to intervene at this level. We recently carried out a study that I would like to share the key findings with you, because I think it's very relevant to policy making. And this is the availability of extremely dangerous drugs like novel synthetic opioids, such as carfentanil. Carfentanil is a novel synthetic opioid which is extremely toxic and powerful, and it's been estimated that it's approximately 10,000 more toxic, more powerful than morphine. So we are talking about very problematic substances that are available. And according to our systematic analysis of the darknet, we found it available. We found 118 listings of this substance on the darknet. So it's available to those who have access to darknet, and they can actually buy this substance. Something related to this is the fact that especially this novel class of synthetic opioids, because they are so powerful, they also been used not only for recreational purposes, but they've been previously used for chemical attacks. So in an age of global insecurity, I would really advise more attention on this type of substances and the illicit drug market. We know, for instance, that a mixture of carfentanil with other substances was used by the Russian forces in 2002 against the separatists, the Chechen separatists, and the accident caused 125 fatalities. And traces of carfentanil were actually found in the clothes of 2 survivors. So it's being used also for these purposes. These substances are extremely toxic and dangerous, so I think more attention should be paid on this side.
Can I just stop you then? So are you suggesting that the substance that were being used by the Russians against insurgents is available in this country to anybody who cares to search the darknet?
Correct. We found 118 listings of this substance by 63 vendors in 19 darknet markets, which is extremely worrying. And I submitted before evidence to different inquiry trying to highlight, this situation. So I think further concerns should be made on this regard. So the substances are so diverse. Some might have potential in therapy, but some are extremely toxic and potentially very dangerous for society.
It's just important to know, fentanyl has been an illegal drug since, I think, 1966. So, it's not as if that's not an NPS, just to share that with you.
my recollection in the run-up to the Act in 2016 was that we had a lot of anecdotal evidence about prison officers becoming affected by the prolonged exposure to this substance, which was being prolifically used in prisons. It was left to the Trade and Standards organisations to actually monitor the head shops, as you called them, Professor Nutt. If what you're saying is true, none of this actually worked in actually controlling the addiction and the social illness that became part of that scene, if you like. What more should we be doing, and what more can we actually do?
Well, the only way you can deal with a problem like fentanyl is to have a regulated market for drugs which are less harmful, so that people don't go on the black market and get it. And, of course, have a much wider rollout of antidotes, so that if people do accidentally take it, because it's not just being used as a heroin substitute, it's now being put into other drugs to give them a bit more kick and give people a bit more of a high. I mean, I think 60,000 deaths last year from fentanyls in the States. They've tried prohibition, it hasn't worked. In fact, the reason we have the rise of fentanyl is because the Americans tried to eliminate other opiates, and the Mexican gangs realized that fentanyl was much cheaper to make than heroin. So we actually, again, it's one of the examples of prohibition leading to these perverse consequences that people look for more potent substances to get around. But the reality is, you need antidotes, you need therapy, and you need a regulated market for things that people want to use. I don't think anyone really wants to use the toxic cathinones, these new cathinones which have come out as a result of the head shops being closed. Before the head shops were closed, they were using weak drugs like methylpropamine, which is just like a strong caffeine. Now we've got these super strong cathinones which have been made to avoid the law. And, again, they're maybe 100 times more potent than the ones people were using before. And they're not being used by people with any experience. So, people, 18-year-olds in festivals are taking 100 milligrams of an ethyl pentolone, and they're staying awake for like 3 days. And the other way we could potentially deal with that, of course, is better testing. So at least if we don't have a regulated market, at the very least we should have open testing so people know what they're taking and can be given guidance as to what the safe dose is.
Would you like to add anything, Professor?
Yes, I do agree. The fact that these substances are now available on the dark, and it makes it for us very difficult, to detect and prevent the harm. So I think focus on prevention it's key on all this. So having a more open public health approach, and look at the motivations behind such use is also crucial. Motivation behind drug taking is constantly evolving as the drug market. So I think the law should be more flexible in this side.
Thank you. Would anybody else like to add anything?
Well, I'd like to ask you about fentanyl. As you've just been having a discussion about that, I understand it's not within what we were just discussing, the psychoactive substances, but I was hearing last week that because of what's happened in Afghanistan and the Taliban now saying that you cannot grow poppies in Afghanistan, that's going to affect the world heroin market. And what I was hearing was that the fentanyl is coming down the track as the next big problem for the UK to deal with. And I think you just made reference, Professor Nutt, to the toxicity of it and the fact that people could overdose very easily on it. And I just wondered, is that what you worry most about in terms of what is coming down the track in terms of drug problems?
Absolutely. The fentanyls are the biggest rising drug problem because they're so lethal. So Ornella mentioned carfentanil. I mean, carfentanil is 1,000 times more potent than heroin. In fact, it's so potent that the people that sell it don't know how to measure it at a safe level, so they have to guess, and that's why they guess wrong sometimes. So the fentanyls, to my mind, are the biggest threat, particularly if there's a drought of heroin, as is likely, as we've seen previously if Afghanistan stops producing. And in fact, we may not be able to stop it anyway because it's the economic returns from making the fentanyls are so much greater than from making heroin.
And just so I understand that, so we're saying that under the current legislation, possession of that substance, because of the way the law is couched in terms of psychoactive substances...
No, they're all Class A drugs.
They're all right, okay, so it is. Sorry, I'm getting confused then with Sorry, what was the one you described? You described two names.
So there are at least 1,000 different molecule structures which are all like fentanyl. So fentanyl was developed as a synthetic alternative to morphine in the 1950s.
Right.
Completely different chemical structure. You don't get it from poppy, you make it in the lab.
Right.
It's been used and it's widely used. Some variants of fentanyl are used by in almost every operation in this country as pain control and sedation.
Right.
But they were pretty much contained within healthcare until about 8 years ago when the Mexican gangs, there was a problem, there was some interruption of the heroin supply. The Mexican gangs realized that actually they could make fentanyl. Fentanyl, the original medical fentanyl, which is about 50 times more potent than heroin, you can make it at about half the price of heroin. So you don't, it's 100 times more cost effective. And the new ones are maybe 1,000 times more cost effective. So the field is moving, it's morphing into fentanyl from opium-based opiates. And some of them, as I said, are so potent that the people that make them, they don't know how to measure it out in small enough amounts to be safe, which is why there are 60,000 deaths from fentanyls in America last year. If that comes to Britain, we will have a serious problem.
Right.
But it's been illegal ever since it was made.
Right, okay. Thank you. Thank you for that clarification. Okay, so we're going to move on to Stuart next.
Thank you very much, and thanks to our panel for your answers so far. If I could go then to the issue of the 2001 regulations, and both Professor Neill and Professor Nutt, you've touched upon the scheduling system there, and I think both been pretty critical of it already. If I could go to Professor Neill first then and ask, could you just give the committee some examples of the types of research that you think have been sort of restricted or limited or stymied, as it were, by these regulations? And also just say a little bit more about how it has this impact. What is it that scientists have to go through to try and get authorisation to carry out research, particularly in relation to Schedule 1 drugs?
Thank you very much. Well, having been through all this myself, I can tell you exactly what the barriers are, and they are significant. To just put this into context, I'm an animal researcher. I've been working in drug discovery for 40 years, looking for better treatments for mental illness. And in all that time, we have not we have not enabled patients to access better medicines than the standard drugs. So I would say psychiatry research has hit a brick wall. Big Pharma pulled out of this area about 15 years ago because this is a very difficult area to work in. But actually now I'm working on psilocybin because it has such enormous therapeutic potential, but it is extremely difficult for anybody in the UK, whether they're NHS working in the pharmaceutical industry or like me working in a university, to do this research, because psilocybin is a Schedule 1 drug, as I've already said. There are four main issues here: cost, huge costs, delay, massive delays, bureaucracy, and stigma. So I'll just deal with each one first. But the other thing to say is that we have exemptions to work with Schedule 2 drugs. So things like cocaine, heroin, ketamine, phencyclidine, which is angel dust, does cause harm. I've used this in my animal model for 25 years. We don't need any special permission to hold these drugs, to use these drugs. And we have all these systems in place to keep safe. Universities are full of dangerous chemicals, and universities, we're all very well set up to keep them safely locked away. But when it comes to a Schedule 1 drug, we need special permission. So the Home Office will say that everybody can apply for a controlled drugs license to conduct Schedule 1 research. So for me, wanting to research cannabinoids, psilocybin. And actually, that I found out that's only partly true. So I applied pre-COVID. It cost me over £3,000 for the license itself. There are a number of additional security features that you need. You need locked, alarmed cabinets, We have all our drugs locked up anyway, but these need to be alarmed. You need to have a registered person, a pharmacist. I'm lucky I'm in a school of pharmacy, to dispose of the drug safely. I mean, I've worked on new chemical entities all my career. We're used to disposing of potentially harmful substances, but we need extra supervision. So that was just the cost for the license. I had to wait a year after the application went into the Home Office, and this is pre-COVID. And you have to have an inspection from the Home Office. You have to renew the license every year, so you have to pay for that. And of course, you don't need any of this for a Schedule 2 drug. The form is very difficult to fill in, so it's a bureaucratic nightmare. I have a lab manager, it took him a week to fill it in. And there's a lot of stigma. So when I want, because these drugs are in Schedule 1, when I wanted to research psilocybin, and this is in animals, the vet was particularly concerned, and we needed a lot of extra checks and balances, which, meant I had to use more animals as well. So that's me for an animal study, and I'm very lucky because I conduct all my research in the same building, so the drug is held in the same place where the animals are. So I decided to do a qualitative study on this, to interview researchers up and down the country to see what their issues were, whether they had similar problems to me. And actually what I found out surprised me and horrified me. So a colleague down in London who was doing a clinical trial with psilocybin, he needed 6 separate controlled drugs licenses. So that's 3,000 for each license. That's a huge delay for each one. That's bureaucracy for applying for each one. So it cost him 20,000 just for the cost of the licenses before he was even able to get the drug into a patient, because every stage where the drug was blinded, where it was put into capsules, where it was kept for the clinical study, those were all separate locations, whereas they have to be for a clinical study. So it extremely disabled his research, and it cost him a lot of money out of his research budget. But I think even more worryingly, when I interviewed people in smaller institutions, people who don't have large research budgets, they wouldn't even consider doing this research. They said it's far too expensive, they don't have the manpower, they don't have the money. And if I may, I'd like to read you a quote from a researcher. They say it's only very, very, very select people that have the potential to do Schedule 1 research, the funding and the workforce. There are so many barriers that have been put up that you have to be a very specific few. You have to be particularly famous, and you have to have lots of grant money and philanthropy money behind you that they are willing to chuck millions at you. It is such an unavailable thing. So I found, and particularly in smaller institutions, I'm lucky I'm in Manchester. Imperial, Kings have been able to fight this, to do it, but it has taken an awful lot of effort and money, which a lot of academics don't have.
In terms of addressing it then, so I mean, you expressed a view that I think psilocybin in particular shouldn't be in Schedule 1, but even if something is in Schedule 1, I'm guessing you're saying all of these different aspects have to be addressed. Do other countries do it in a completely different way? Do we need a radical overhaul rather than just tweaks?
Yeah. I mean, as I said, psilocybin has enormous therapeutic potential. There are 40 clinical trials going on around the world at the moment. And actually, this is a huge economic value. The psychedelic research industry is worth $2 billion last year, and it's predicted to rise to $10.7 billion by 2027. This is an emerging, growing market. People are developing new drugs, but they will all be in Schedule 1 in the UK unless we change the law. So people will not conduct their research here. Companies will not come here. I'm working with one company who's just opened a facility in Canada because there are lots of different countries in the US, in Oregon, in many cities. They have changed their laws. In Canada, in many parts of Europe, in Spain, we heard about Portugal, to enable this research and to enable this to happen. And in fact, St. Kitts have no restrictions, so you can in terms of developing drugs for patients, running clinical trials, and doing all the basic research. The other thing, so psychedelic or psilocybin, the main indications at the moment are for severe illnesses, PTSD, depression, and the anxiety and distress that occurs with a terminal diagnosis. I've actually brought a couple of testimonials with me from patients, if I get time to read those out. But it's absolutely essential that we are enabled to do this research in the UK. And removing psilocybin from Schedule 1 would enable that. As I said, we don't have any restrictions. We don't need any special permission to research Schedule 2 drugs.
If you could submit those in writing, that would be helpful, the testimonials, that would be brilliant. Professor Nutt, is there anything you want to add in relation to the impact of...
Yes, I mean, I'll just say, so I'm one of these fortunate people who's been around for long enough to fight through the regulations. And you have this absurd situation where I have to have a special safe in a special room with a camera to put my psilocybin, and I say to the home, I say, why can't I store it alongside the fentanyl and the heroin and the cocaine I work on, which is in the pharmacy? And they say, you can't do that because it's a Schedule 1 drug. So, I mean, what is the logic in that? If anyone was to break in, they're not going to take the psilocybin, they're going to take the fentanyl and the heroin. So one of the simplest thing you could do immediately would be simply to say all universities and all hospitals are Schedule 1 exempt as they are Schedule 2 exempt. So that would be something you could just do at a stroke. I don't think it needs an Act of Parliament even. But I would certainly think we should also be looking more specifically at moving the drugs where we have clear medical evidence now. I mean, probably 1,000 patients now have been treated with psilocybin for a range of disorders. It's in many ways the most effective treatment we've ever seen for severe depression. What more evidence do you need that it should be studied as a medicine? But the studies are being delayed, particularly in the UK. So we pioneered the use of psilocybin in depression. We published the first paper 6 years ago. There are 40 companies now doing research based on that particular discovery. But very little of it's happening in Britain because every single site, every pharmacy, every hospital, every academic needs to get the license. And it's just too expensive and too time-consuming.
Thank you very much.
Thank you. I'll just take Adam Holloway and then I'll come to Tim Loughton.
Thank you very much. I mean, I thought you could find psilocybin in virtually any farmer's field from time to time. I mean, an observation, I've got a friend called Matthew who goes to the Netherlands to microdose on this stuff, and it has pretty much fixed his depression. But, I mean, it does seem very odd. I mean, it's almost like it's sort of superstitious about this stuff. I mean, what is it about us that we create these great regulations on, respectable researchers such as yourselves?
Well, I think you need to answer that rather than me. But from my perspective, the two...
Yeah, well, you've been the victim of it for many years. So what do you think the root of this is?
Well, I think it's several things. I mean, the psychedelics particularly they were banned by America because the anti-Vietnam War movement was also associated with the use of LSD. And they couldn't ban protests against the war, but they could ban LSD. So America banned LSD in 1967. They sucked in pretty much all the other psychedelics like psilocybin. And because our drug laws are largely the same as Americans, the Misuse of Drugs Act was driven by America. Basically everything we've done has been to comply with their attitudes. Why they're against these drugs? So it started off political. It ended up being much more puritanical and hostile to drug users generally. But there is no logic to it, none at all. But you get into this cycle that people are terrified of changing the drug laws. I mean, some of you will remember the debate about cannabis. Cannabis once was a Schedule A or a Schedule B drug, depending on its form, and then it was downgraded by David Plunkett to C. And the hysteria about just changing the position of something in the Misuse of Drugs Act was bizarre, both in here and also in the media. So a lot of it is about not wanting change, and I think also in the medical profession, there's also a resistance to admitting they were wrong. I mean, people still say to me, well, of course, if it's a Schedule 1 drug, it must be very harmful. And I say, well, what's the evidence of that? And they say, well, it must be because it's Schedule 1. And it must be addictive. But it's not addictive, it's anti-addictive. But we can't use its anti-addictive properties because we can't study it. The other thing about the Netherlands, though, the Netherlands were very clever. The Netherlands realised it. In fact, we were quite clever to start with. We didn't ban the mushroom until 2005. We banned the drug, the active ingredient, psilocybin, but the mushrooms were legal in 2005. And then political machinations between David Cameron, goading Tony Blair. Tony Blair was soft on drugs, persuaded Blair to make the mushrooms illegal alongside the active ingredient, psilocybin. The Dutch were different. The Dutch realised this whole thing was pretty absurd. In the same way as they freed up cannabis in a regulated fashion, they kept the truffle legal. So the truffle's the bit that goes under the ground. So the mushroom is illegal. So that's why you can go to Holland. You can actually go and get the truffles because they're not illegal in the Netherlands. And it's a huge business for them as well. If people come to me now and say, people in my trial, we've put 60 people through trials with psilocybin. Many of them have done very well, but some of them, the depression's come back, and they say, "Can you give me another dose?" I say, "I can't give you another dose because I don't have a trial going. I can only use it as a trial." So we say, maybe go to the Netherlands, maybe try it there. And there is actually, it's a serious business. My top therapist is now working largely in the Netherlands because she can't work here. There's no work for her here.
Okay, thank you. Tim Loughton.
Thank you, Chair. Professor Reece, can we come back on cannabis? And you mentioned earlier that it's a gateway drug. Professor Nutt made the interesting comment about it's a gateway drug because of how you get hold of it rather than the impact it has on individuals. What are the medical harms, potential medical harms that it can cause? You cited 3 dangers because of greater concentration, greater usage, and greater, more regular usage by those who use it as well. So can you go into a bit more detail about the actual medical harms? You touched on cancer. I believe it burns at a much higher temperature, for example, which can do more damage to lungs, etc., etc. Can you give us some details on that?
Yeah, well, that's a very large subject, so thank you for your question. It's got a lot of effects on the brain, obviously. There's a lot of cannabinoid receptors in the brain. As you say, it's smoked up, it hits the lungs, and it can cause chronic inflammation in the lungs. It can cause chronic bronchitis. It's linked with a higher residual volume. That's a medical term. It's the sine qua non of emphysema. And it's increased respiratory symptoms. It can affect the reproductive tract, that's known. It's very active in the liver. It perpetuates liver inflammation and is a known liver carcinogen, so it causes cancer in the liver. And it's affected the brain. It's linked with mental health issues. And you understand, of course, that inside every cell there's genes. And the genes have a control system. The body has thousands of different kinds of cells, and the DNA in each cell is essentially the same, but the cells themselves are very different. So it must be that the way the genes are controlled, the way the genes are used in each cell is different. Now that control system for genes is called, the medical word is the epigenome, which means upon the genes or after the genes or on top of the genes. That's the control system for the genes. Think of it like a computer. If you get a new computer, you get a hardware and you get the software that runs the computer. And cannabis has a very big, we would say, epigenetic footprint. And that is part of its overall genotoxicity. So the toxic effects I just mentioned, including driving, which is part of the neurotoxicity, are what we call the classical picture of cannabis toxicity. More recently, the first study on cannabis genotoxicity was published in 1969. So this is a well-established area, and there's lots of papers on it in the literature. But we've conducted studies recently to say, okay, cannabis has a well-established genotoxic effect in the lab. What are its effects in people, in the clinic? And the stuff's been widely available. And we heard earlier about Portugal and Spain and parts of France where cannabis is widely used. And this is well known. The Netherlands, of course, that's well known internationally. But these countries also are top of the pops, if you like, within Europe. And we've got papers just published and more papers coming out to show that inherited congenital birth defects to babies on the brain, the heart, the bowels are much higher in the Low Countries, Netherlands and Belgium, parts of Spain.
Professor, it's obviously a very big subject. Let me just come back, and I can see some frustration from Professor Neill, so she might want to come in after in response to some of those points. A lot of what you've described is the impact of smoking cannabis. Presumably some of the genetic and other impacts you've described are as a result of ingesting cannabis in whatever form into the body. So are there much safer ways of consuming cannabis, and are there levels at which you can say there are medicinal benefits, particularly for people with the three classes of ailments that we know, but there may be some medicinal benefits that can outweigh that harm to the various parts of the body that you've described. So what I'm driving at is there a way of people taking cannabis with only minimal harmful effects, but with potentially rather more positive medicinal impact on conditions that they may have?
Well, that's also a good question, sir. I think, as you know, cannabis can be eaten in cookies, and it may be that would reduce some of the toxicity on the lungs and the throat and the upper airways. That may be the case. I'm not sure that there's any particular research on that. The effect on the brain, the liver, the ovaries, the testicles, the heart, the arteries, they are not related to the inhaled route of cannabinoids. They are just related to the actual pharmacology of cannabinoids themselves. The three key hallmarks of genotoxicity are aging, cancer, and birth defects. And we've found very strong signals in all those three key areas. And there's a recent paper using state-of-the-art epigenetic clocks that showed at the age of 30, cannabis users were 30% older than normal. So they've only got one time point in that study. They don't know whether they're 30% older at all ages, or 40% at 40 years, or 50% at 50 years. We don't know. The research hasn't been done. But just that datum point alone, 30% older at 30 years, with the state-of-the-art epigenetic clocks, has horrifying public health implications. You roll that out across your population, you have an unsustainable health budget.
Okay, and so presumably there is evidence which will show that contemporary use of cannabis, which tends to be much stronger, the skunk compared to the weed, or whatever you call it, back from the 60s, is far more damaging in those areas, as well as the higher incidence of people who do smoke or take cannabis doing it on a much more regular basis. So people are being impacted far more now than they would have been 40 years ago with a different type and a lesser use of cannabis. And there's evidence to show that, yes?
Yes, that's what the data shows. That's correct, sir.
Thank you. Professor Neill, do you want to come back on some of those comments you were frowning at?
Hello, sorry. I was just trying to concentrate. I'm really not a cannabis expert, but I have done some work. We did work for GW Pharma on numerous cannabinoid molecules, CBDA, CBDV, THCV, CBD, THC in the animals. And I'm just thinking they brought two products to market, GW, containing cannabis. They must have done extensive toxicology studies in animals. We did a lot of work. It was all to test whether they were likely to work. But they must have a lot of information, and I would have thought the drug would never have got to market if there were genotoxic effects that they had seen, certainly in all the animals. I know from my experience in drug discovery that work in animals, in rat, in dog, is extremely extensive before any drug gets to market. But, I think Professor Nutt is much more of an expert on cannabis than I am.
Excuse me, the registered prescribing information for Sativex and Epidiolex has the genotoxic warnings if you read it, because, like I said, this stuff's been known for decades and it's been confirmed many times. And if you read the stuff, you can see the warnings about use in pregnancy and use in breastfeeding, and don't take this if you're going to have a family, which are classic genotoxic warnings. Ma'am, your information is only fragmentary on that point.
Can we come to Professor Nutt and Professor Corazza on that? I mean, are there clear medical benefits from cannabis use in regulated circumstances? And why is it, again, I'm not an expert on this, that most people who use cannabis still smoke it, yet smoking prevalence of tobacco is coming down, and everybody agrees that it's not good for you. So why has there not been a bigger move across to everybody having hash brownies or whatever it is, different, or what do you want to call them, different ways of which I'm not aware there is. So why do people still choose to smoke it for whatever reason?
The advantage of smoking is it gets in very quickly. I want to correct one thing. Actually, cannabis burns at a lower temperature than tobacco, and it's less harmful to lungs.
My understanding is that skunk and much higher concentrated cannabis now burns in the lungs at a much higher temperature than cannabis weed used to. Is that not?
Out of the, I mean, unless I'd be interested to see the data. I don't think that's true. But there are some ways you can manufacture strong THC, which might be different. But the cannabis plant burns at the leaf burns at a lower temperature than the tobacco leaf. In fact, that's research that the ACND did when I was part of them. The reason people smoke is, if recreationally, is because you get an immediate effect. Now, of course, clinically, that's also very important. The way we provide rapid onset medical cannabis for people in pain is to use a new kind of vaporizer. So you don't burn the leaf. You heat it so that the active ingredients go. So that's the first thing. We can actually reduce the risk to the lungs by vaping, but not putting it in liquid, but actually just heating it through a special vaporizer. But we are, and as you may know, Drug Science has now got 3,000 patients in a trial, in an audit of medical cannabis. And we're encouraging as many as possible to move from the heated products to the oils, because they have a better time profile, and also you don't run the risk of the potential risk from getting hot vapor into your lungs. And there's one thing I really want to say about this, because this project has showing a lot of fascinating data, but one of the most intriguing things is that we've now analysed, I think, about the first 500 people who are using medical cannabis for chronic pain. And 44% of them have stopped using opiates. They've stopped using opiate painkillers. 44%. Now and we didn't ask them to stop. We just monitored what they were doing, because cannabis provides such a significantly better control for their pain than opiates. And that fits in with other research we've done.
Thank you. Do you want to add anything, Professor Corazza, on medical benefits?
I don't think I have anything else to add on that. I'm not an expert on medical cannabis.
Okay. Thank you.
Diane Abbott.
I just wanted to ask a little bit about drug addiction and treatment of drug addiction, because, I think most normal people, unless they spend a lot of time reading the tabloid press, are more concerned about drug addiction and how you treat drug addiction than anything else. I wonder if perhaps, Professor Nutt, you've got any observations to make. And also, has treatment for drug addiction become more effective over time, or has it stayed the same in terms of the numbers of people helped?
Well, the effectiveness of treatment has declined, and I think Emily Finch in the next panel will talk about that, because she is very much in the front line there. But I think that's largely been driven by the reduction in funding, because there has been a significant attenuation of funding for addiction services over the last 10 years. And thankfully, I think that's going to change with the Black Report. It'll put us back to where we were, but there's no question that there's been an unfortunate hiatus in terms of appropriate funding. In terms of the treatments, there's been relatively little innovation in new treatments in a very long time. We're still using drugs like buprenorphine for opiate addiction or methadone. These were drugs which were invented in the 60s. And one of the reasons that myself and Joe Neill think it's important we facilitate access to drugs like psilocybin is that there is some evidence that they can be used to treat addiction. Currently, there are studies going on with ketamine, this is a Schedule II drug, but there is definitely preliminary data suggesting that for tobacco smoking, for alcohol addiction, that psilocybin may be even better. And that is the study that I want to do next, but again, the limitations of the Schedule I status really makes life difficult for me.
And so, as you've indicated, the 10-year drug strategy promised to invest, I think it's 780 million to rebuild drug treatment and recovery services in England and Wales. Is that enough?
Now, that'll put us back to where we were, I think, in 2010. I think we probably should double that, and particularly in terms of funding research. I mean, my biggest criticism of the new strategy is it didn't explicitly dedicate funding for research. And as I say, there's an opportunity for serious innovation in addiction treatment now using these illegal drugs.
And are there types of treatment that are not currently practiced in the UK that you would recommend adopting?
I wouldn't recommend adopting, but I definitely recommend researching. I mean, for instance, Ibogaine. Now, internationally, there's a lot of use of Ibogaine to treat heroin addiction, but it's never been properly studied. I can't tell you if it works or not. I can't tell you if it's safe or not. I want to study Ibogaine. Again, it's a Schedule 1 drug. Very difficult for me to study. It wasn't. I could study it.
Thank you very much. Thank you, Chair.
Adam Holloway.
Thank you, Chair. Can I ask Professor Reece, because you seem to be a sort of a lone voice here, what do you think Britain should do to reduce the harm caused by these drugs?
Well, as I mentioned earlier, sir, I think we need much better public education on the harms. And just touching on the point which was just discussed about rehab and detox and helping treatment, there's been a change recently in Australia. Cannabis is more freely available, and with it, the demand for cannabis treatment has plummeted. We used to do a fair number of detoxes for cannabis, which is relatively straightforward medically. But now people just say, oh, it's medical, I'll just jump on the medical program and that way the law can't touch me. So I think it's very important that the committee have a clear understanding that the illegal status of drugs is one of the motivating forces to enter detox and treatment, because for a lot of patients are very ambivalent about whether they want treatment or not. So the fact that there are restrictions and legal sanctions against it is one of the major factors which tips the balance in favour of treatment. I think education, as I mentioned earlier, especially on cannabis, the genotoxic health impacts of cannabis are not understood. But if you think that a huge percentage of exposed children in utero are going to develop autism or have serious birth defects in their brain or heart or limblessness, as we've recently reported, then the whole picture takes on a totally different game altogether. So I think one of the big issues in this whole addiction drug field is that people are not on the same page. And I think if the research, which is being increasingly brought to bear and made evident in this area, needs to be much more widely known in the community so that everyone will be on the same page and we can sit down and have a rational discussion.
Forgive me, everyone in this room knows that drinking alcohol isn't particularly good for you, but I guess most of us in this room drink too much. I mean, what you're saying isn't the answer, is it?
Above the regulated and raw.
But we know that doesn't work with alcohol. So, but what we're not doing with alcohol is creating an illegal market. It's a medical issue, not a criminal justice one. So, how does that fit with what you just said about educating people?
And I'm going to ask you to be very brief, actually, because we are running out of time.
Yes, well, I think we need much better education on this area. And just to touch on a point earlier, you were talking about fentanyl and carfentanil and the dark internet. To me, the law that you talked about in 2016 sounds relatively successful. The head shops were closed. What you have there is a cybersecurity issue, and you need to involve cybersecurity experts to intervene in the dark net. That would be my comment there.
Thank you. And I'm just going to very briefly take Stuart MacDonald, very briefly.
I just wanted to ask Professor Nutt in particular to come back on two or three of the points that Professor Reece had raised. So, for example, this idea that it's the illegality of drugs that drives people to seek treatment. I mean, most of the written evidence that we've received seems to suggest the opposite, that that's actually a barrier to people seeking treatment. Secondly, the idea of cannabis as a gateway drug, when it seems to be the countries where cannabis has been at least decriminalised, or regulated, where people have less access to other drugs from the source of their cannabis. And then finally, just your view on whether cannabis should be Class B, Class C, or whether possession should be decriminalised altogether.
Well, starting with the last one, I think it should be decriminalised because criminalisation of cannabis users has led to enormous social problems. I mean, you've got a vast, hundreds of thousands of young black men with criminal records for possessing cannabis. It's outrageous. In terms of does the law facilitate treatment? You're right, it doesn't. In fact, as a Nobel Prize-winning economists have said, that the black market is way the best market. It keeps people in addiction. It denies access to treatment, and it doesn't give governments any kind of taxation. And what was the middle one?
The gateway point.
Gateway. So yes, I mean the gateway argument is an interesting one. It's been very powerful, but the reality is when you deconstruct it, you discover that the Dutch were right. The reason the Dutch set up the cannabis coffee shops was to separate the cannabis market from the heroin market. They didn't want their young people to be offered heroin, and it was a remarkable success because they have less use of cannabis in their young people than we have, because there's no black market driving it, and they have way lower use of heroin than we did. So it was a perfect solution, and we should definitely adopt it here.
Okay, thank you very much indeed. Can I thank everyone who's given evidence in this part of our session this morning? It's been very stimulating, and I think we've all learned a lot as well. So thank you very much for your time.
Thank you.
And we'll now move on to our second panel.
Thank you.
Simon's?
Yeah, I'll just open. Morning. I think we're just waiting for our third panel member to come on screen. Good morning. Can you hear us okay?
Yes, thank you.
Yes, good. Okay. Well, welcome. This is the second panel of this morning's evidence session. I'm going to ask, as I did with the first panel, if everyone could introduce themselves and just to say in what capacity they're speaking this morning. I wondered if we could start with Dr. Bowden-Jones.
Yes, good morning. So my name is Owen Bowden-Jones. I'm chair of the Advisory Council on the Misuse of Drugs.
And my name's Emily Finch. I am joint chair of the Recovery Committee of the Advisory Council on Misuse of Drugs.
Professor.
My name's Roger Knaggs. I am a council member of the Advisory Council on Misuse of Drugs and chair of the Technical Committee.
Thank you. And as I said to the previous panel, it would be very helpful if everybody could use simple and straightforward language, as we're not all scientifically trained on this committee. So that would be very helpful. If I could just start us off, actually, with your assessment, perhaps, Dr. Bowden-Jones, about the classification model that we've been discussing this morning, and whether your view is that it is fit for purpose in terms of controlling drugs.
So perhaps I'll preface that just by outlining the role and the limitations, in a way, of the work of the Advisory Council. So we're an independent scientific Advisory Council. We have a statutory role within the Misuse of Drugs Act, and we are a group of 23 experts drawn from a range of different disciplines. We make recommendations to government on issues such as scheduling and classification, but also on a range of other topics, which I imagine we'll probably be touching on today. What we don't do is develop policy or undertake direct research ourselves. So I think it's just important to be clear about that right from the beginning. So coming to the classification system, I mean, this is not something that we have studied. So we have not undertaken, examined or undertaken research on the classification itself. So it's really difficult for us to comment on the classification and how it works. What I can say, though, is how we make decisions with respect to recommending a certain drug going into one class or another. So what we've done, we've actually published this because we felt it was really important that people were clear on how we reach decisions. And so we have a very clear description of how we seek evidence, how we synthesize that evidence, and how we present that evidence. And also included in that document, which we're very happy to send to the committee, is a health and social harms matrices. Now, this is really important because what this allows us to do is be very systematic in how we look at a drug and the harms it might cause. And so we go through this health and social harm matrices in detail, making sure that we've not missed anything, but also allowing us to do a sort of clear and comprehensive review of each substance we look at. So that's the process by which we go through. We then, of course, make a formal recommendation in writing to government, and it's then the government's decision whether they choose to accept that or not.
Would you like the power to be able to take evidence about the system that you're operating in and whether that's the best system and whether it could be improved? Would you like that opportunity?
So we've not been commissioned directly by government to
no,
look
but
at this.
Would you like it as the chair? Would you think that would be a good thing for you to be able to do?
So we do actually have a process by which we can self-commission work, and in fact we do self-commission work regularly. And the process by which we do that is we have an annual meeting where we look at all of the priorities, and then we develop a list of those, and then we choose the ones we feel are most important. In terms of the things that have come to the top of that list, our main focus has been around drug-related deaths. So the focus of the reports we've self-commissioned have very much been in that space. So to give you examples, we've done reports on naloxone, we have done work on the sort of substances you were hearing about in the first session, which are added into heroin supplies. So, for example, novel benzodiazepines. We've also done a lot of work on different vulnerable groups to try and understand and explain to government the science behind some of those vulnerabilities.
So there is the possibility in the future that your organisation could look at the classification model if it wanted to?
Yes.
Right, okay, that's interesting to note. And then you're very clear, I expect, that you are there to provide the recommendation, the evidence base to ministers, and ministers make the final decision?
Yes, that's our role.
And that's clear. That's because obviously in the past it's been difficult for your organisation. There's been certain tensions between politicians and chairs of the committee.
So I think the role is really very clear, and it's described very clearly in the Misuse of Drugs Act. I mean, we're an independent scientific advisory committee. When we function well, we are providing the science and synthesising that in a way that ministers can clearly understand what the science says. It's very much for the government then to decide what to do with those recommendations.
Okay, thank you. I'm going to move on to Carolyn Harris.
Thank you, Chair. We heard in the last session about the prevalence of the dark web and the damage that is doing to allowing people to access psychoactive substances. With your work looking at the social harms, what more can we be doing to actually prevent that and to support people to come away from that environment?
This is a very concerning area, and it's actually an area that we already have initiated a report on. So we have a working group at the moment looking at internet-facilitated drug markets. Now, obviously, I can't comment on the findings of that report yet, but it's something that's a high priority. What I would say about many of our reports is there is a theme that comes across which I think is important just to sort of mention, because what we tend to find when we look at the evidence is that no single intervention on its own tends to be enough. And so what our reports tend to be suggesting when we look at the evidence is that there's a range of different approaches that you have to look at and take together as a package. And a really good example of this is our GHB report. So GHB is a substance that was associated with a number of very high-profile sexual assaults and murders in the UK. The Home Secretary asked us to look at the classification and scheduling of that substance and group of substances. And when we looked at the evidence, what we found very clearly was that no single intervention was likely to be sufficient to reduce the harm. And so alongside the recommendations we made around classification and scheduling, we made a lot of additional recommendations looking at treatment, the training of clinicians, the information that's given to people who use these drugs, harm reduction information on toxicology and how you might measure the harms that are caused. And so we were very clear, and this is a theme across many of our reports, that a single intervention probably won't lead to the reduction in harm, but this broader approach where you sort of knit together lots of different evidence-based interventions is really the way to go.
When you advise government on the methodology that you see would be most effective, are you knocking on an open door?
So there is a working protocol in place between the ACMD and the government, which really sort of outlines how this relationship works. So all of our recommendations are put to government in writing. They're all published on our website so everybody can see them. The government responds to recommendations in writing as well. Now, some recommendations are accepted and some are rejected, and there is a clear process in the working protocol about how we manage that. So when government rejects a recommendation, then the working protocol is very clear that what happens is they need to write to us explaining the reasons for that rejection. And very typically what will happen is I will meet with government and discuss that face-to-face as well. So that's the sort of framework that governs our interaction.
Thank you, Dr. Bowden-Jones. No more questions from me.
Can I just ask, is there a time frame around that process? Because one of the concerns we have is that often things take an inordinately long time in the Home Office. Do you have a time scale for each bit of that process?
So the working protocol suggests that we should receive a response within 3 months of submitting our recommendations. Now,
do you?
Well, we don't always, and we do acknowledge that sometimes we write, as I've described, these recommendations that are aimed at more than a single department, and so we'll quite regularly write recommendations that of several different government departments. And I sort of acknowledge that the more complexity that we perhaps present government with, perhaps the longer it will take them to respond. But one of my roles as chair is to try and sort of encourage government to respond as in a timely manner, and that's sometimes difficult. The pandemic, I don't think, has helped with some of the responses, but there still is, as I say, within the working protocol, a clear time frame.
Okay, but it sounds like it's breached more than observed.
I'd have to go back and look exactly. I mean, certainly some of the reports and the recommendations have certainly breached 3 months.
Okay. All right, thank you very much. Stuart MacDonald.
Thank you very much, and thanks to our panel for coming along this morning. I suspect my questions would probably be best directed at Dr Knaggs, but if anyone else wants to come in, please do. In the last panel, both Professor Nutt and Professor Neill expressed considerable concern about aspects of the 2001 regulations and the system of scheduling drugs and the impact that has on research. Is it your view that the way drugs are scheduled just now, Schedules 1 to 5, reflects the potential harms of all of these drugs and is a system that's fit for purpose?
Thank you very much. I think the first thing I'd actually like to say is just like Dr. Bowden-Jones described the approach we have to classification and making decisions regarding classification, one piece of work that the ACMD has undertaken over the last couple of years has also been to look at the process and the criteria as to why specific substances may be scheduled within the different schedules within the misuse of drugs regulations. And again, that would be a document that we would be happy, is freely available, and we would be happy to share with you in terms of the considerations that allow or that we look at when we're considering making a decision regarding scheduling.
But by way of example then, so psilocybin was one of the complaints of the two professors. Are you able just to give us a brief summary of how psilocybin ends up in the first schedule?
I think the first thing to remember is that many scheduling decisions were made a long time ago, and so many of the schedules that drugs are in currently are historical decisions that may have been made many years ago, and although they are as new evidence comes to light, then they may well be reviewed.
Should there, so what you've mentioned new evidence as a trigger, but should there be some sort of automatic process of reconsidering the scheduling of drugs, or if somebody like Professor Nutt or Professor Neill makes a submission that's in the wrong place, rather than just sort of leaving it there and from what I'm getting from you really is that there are things that are wrongly scheduled now. Shouldn't there be some sort of automatic review process?
One of the key defining features between Schedule 1 and Schedule 2 within our document relates to the availability of licensed medicinal products, and at the moment there are no licensed, and there is obviously through the MHRA a process regarding licensing of medicines. And that is one of the key factors that distinguishes between Schedule 1 and Schedule 2.
Okay, now I'm sort of venturing into territory where I'm not remotely knowledgeable, but isn't there a sort of risk of a chicken and egg situation there? I mean, how are you going to get a licence under the MHRA system if you aren't able to undertake the research, or all of these burdens are preventing research happening in the first place?
There is a very clear process in terms of undertaking research, and the MHRA do allow research with Schedule 1 drugs for investigational purposes, and there is also the ethical approval process through the health research that is required in order to undertake clinical studies.
The evidence from Professor Nutt and Professor Neill was if they want to do research in relation to Schedule 1 drugs, they have significant expense, significant bureaucracy, significant delay, and that this is overall having a really detrimental impact on the research that they want to do and many others want to do, which could bring enormous health and indeed economic benefits to this country. Are you quite relaxed with the system as it is just now, or do you have some sympathy with the complaints that they are making?
Barriers to research is an issue that has been on the ACMD agenda for several years now, and this began and was highlighted to the ACMD as an issue following a generic definition regarding the synthetic cannabinoids, and we have been working to understand these barriers over the last 2 or 3 years, and in summer 2021, we published a report on barriers to research, specifically relating to the synthetic cannabinoids. And we are currently, last year we had a call for evidence regarding barriers to research more generally with particularly Schedule 1 controlled drugs. And this is a piece of work that we are currently working on at the moment.
When do you expect that to be completed and publicly available?
As you can imagine, this is a very complex area, and we are intending, we are looking at all stages of the discovery process, from drug discovery, so the types of more laboratory-based research, through to the development of new medicines and also clinical trials as well. So it's and the issues are probably slightly different in each of those areas. And as I say, this is an area that we are currently working on, and we hope to be able to publish a report during this year.
Okay, thank you very much. I don't know if Dr. Bowden-Jones or Dr. Finch wants to add anything. I mean, even just on a very simple level, what Professor Nutt was saying about even the storage of psilocybin in a safe with a camera looking at it, where he says, well, why can't I just keep it in the cabinet next to other drugs which would be far more attractive to anyone who is trying to break into his pharmacy? Surely there has to be some sort of look again at these rules.
So if I could make a comment, we're absolutely aware that Schedule 1 puts extra burdens upon research, and we're very sympathetic to people who are trying to do research. It's critical that legitimate research occurs in the easiest way that is possible. There is a balance, of course, between sort of allowing legitimate research to occur, and these sort of safety checks and balances that you'd expect over substances that have been put in Schedule 1 typically for a reason. Now, as Professor Knaggs has described, this is an issue we've been working on for a long time, and it is actually very, very complicated, because there are different types of research undergoing, and the problems are different for the different groups. But we are very, very committed to this. We have, as Professor Knaggs said, already provided recommendations to government around the synthetic cannabinoid receptor agonists. We are now moving to look at all Schedule 1 drugs. And we, as Professor Knaggs said, we're very much hoping to come back with recommendations by the end of the year that might then find some way around this issue, because we recognise it's an issue and we want to try and find a way around it.
Thank you very much.
Loughton.
Thank you. Can I just follow up on that? So you've said earlier, Dr. Bowden-Jones, that you are looking at drugs in terms of their health and social harms, and then we've heard that you will only look at rescheduling a drug if there is new evidence. Now, clearly, there's sort of new evidence under not just health but social harms emerging all the time, the way other countries have chosen to reclassify or reschedule their drugs, whatever system they use. So is there not a case, as we've heard just now, that there should be a routine analysis every X years to make sure that everything is scheduled in the right schedule, rather than slightly randomly relying on some new evidence in whatever form to come along before you'll actually look at it?
So the Advisory Council has a sort of watching brief on drug harms, and so we have various committees, subcommittees that do keep an eye on emerging drug harms. We've got lots of different metrics that we look at to try and identify harms that are emerging. Similarly, on the medicinal side, particularly around the scheduling, the Medicines Healthcare Regulatory Agency will inform us if new medicines are being brought to market and that those need scheduling. So there is a process by which, as new medicines appear, we are alerted via that system. But I do agree with you. I think the the idea of having a more systematized approach to review would be helpful.
Presumably would there need to be legislation to change that? Would the Minister have to give authority for that, or is that something that you could change your own processes? How would that come about?
Well, as I said, we do have processes in place to have a continued review of emerging drug harms, so that's already in place.
You could just change your practices effectively?
Well, as I said, our practices, we feel, do pick up emerging harms. I think the issue you're saying is, if I've understood you correctly, is what about the things that are already in
No, that's exactly my point. I mean, so for me, I have prescriptions for various long-term conditions, and my doctor will routinely, each year, look at, is that still fit for purpose? Do I still need that drug? Should I change the dosage or whatever? It just seems odd that you are at a much higher level, sort of regulating some of those things. You're not routinely seeing whether your advice and your scheduling classification is still fit for purpose on a routine basis anyway.
Well, we do review, as I've said, emerging harms. So, for example, if a drug within that has been classified as within the classification, suddenly we started hearing that there were harms associated with that, then actually that would be something we go back and review. And we have reviewed drugs at sort of fairly regular intervals over the years. But I think it's an interesting point, and it's something I'd be very interested to take back to Council and discuss.
Dr. Finch, let's hear from you. Can we come on to cannabis? And you would have heard the comments we had earlier about medical harms for cannabis. And again, picking up your approach that you look at health and social harms. So what are the health and social harms then as regards cannabis and cannabis alternatives?
The ACMD haven't looked at cannabis since 2008, I think, which was, in fact, before my time on the ACMD. So we haven't been commissioned by government to look at the harms of cannabis, and we haven't also self-commissioned ourselves. We've focused on the areas that Owen was talking about. So we haven't reviewed the scientific evidence for 15 years.
So your scientific review is 14 years potentially out of date?
That's right, yeah.
And you have to be prompted to look at that by government, do you? You can't just instigate a...
We could, in theory, as Owen said, we have a process by which we decide what we look at. From my point of view in the Recovery Committee, we focused that review on particular vulnerable groups. So different drugs have come up, but we've focused those reviews on homelessness, for instance, and other forms of reducing harm. So we haven't looked at cannabis.
Do you not think there's a case for looking at this again? Obviously, we've heard that the medical impact of cannabis is being used, and there's more research and availability commercially of certain drugs which can be seen to help.
We have looked at cannabis-derived medications.
Right.
So we haven't looked at the use of illicit cannabis. What we've looked at is around the provision of medicinal cannabis, which we've done a significant amount of work on.
Right. But in terms of illicit cannabis, then we've heard about, from Professor Reece, that the very damaging impact it can have on all parts of your body, and that it's stronger now and taken more regularly by the users, etc., etc. So, in terms of a social impact, surely quite a lot has changed over at least the last 14 years. So, do you not think you should be able to have a proper look again at the illicit use of cannabis?
Yes, I mean, there's a case for it, but we have a lot of other priorities. Increasing drug-related deaths is an example. Other treatment priorities from the Recovery Committee's point of view. We've just talked about the barriers to research. We have a limited amount of resource as to perform our work programme. It's something we could consider.
So it's a resource issue?
Perhaps. It's also a prioritisation issue.
Okay, so what is your view? So if resources were not an issue, do you think you should be looking at the scientific evidence around the health and social harms of illicit cannabis on the basis that your evidence could now be 14 years out of date?
I think we would have to look at other issues and prioritisations for the whole work programme in order to make that decision.
Slightly fudging the question, if I may say so, how everything is a priority. How big an issue do you think this is, given that cannabis is the most common form of legal drug that is taken?
I mean,
perhaps over to you.
Yes, perhaps I can.
From the social impact, because I was interested when you say you look at health and social harms.
Yes.
The social harms covers a multitude of sins, and it goes into the whole crime stats and everything we heard about earlier. So I'm just slightly concerned that your evidence is 14 years out of date, and this is a big and growing problem.
So I think one way to think about this is the context of the drug problems in the UK at the moment. And I think the clear challenge that we see is around drug-related deaths. So very few people, to our knowledge, are dying from cannabis, but we have very large numbers of people who are dying from opioid-related substances. And so we've been putting enormous energy into trying to marshal the scientific evidence around the drug-related deaths and things that are contributing to those deaths to try and inform government of the science behind that. So there are always issues that are important, interesting, that need to be discussed and could be discussed. But I think in the context of what's going on in the UK at the moment with respect to drug-related deaths, I think it's quite appropriate the ACMD is sort of placing its resource looking at that issue.
Do you not buy the argument that cannabis is a gateway drug into harder drug use, which does result in drug-related deaths?
Well, going back to our 2008 report, that wasn't a particular feature of that report, so there wasn't particularly much science related to that. Again, I think the group of people we're seeing who are experiencing the harm from drug use at the moment tend to be largely focused in opioid users. And actually, this is a huge and devastating problem, and it's getting worse. And so we feel very comfortable with focusing our energies looking at things like naloxone provision and why that is always not happening properly, looking at opioid substitution treatment and giving evidence around that, looking at these new adulterants to heroin markets and the harm that those are causing. And I think this is an absolute priority for ACMD, and I'm very comfortable with that priority.
Briefly, Professor Knaggs, did you want to add anything? Professor Knaggs, did you want to add anything?
No, thank you. Sorry.
Okay, thank you, Chair. Thank you.
Thank you. Could I just ask you a question, because you were talking about reviewing and the opportunity to look again at things. So I just noticed your report on fentanyl in 2020, where you were basically saying that you didn't think it was much of a risk to public health in the UK at that time. I don't know if you were, I think you were in the room when I was raising this issue about fentanyl now being seen as a real problem because of what's happened in Afghanistan. So just explain to me, has that report's been accepted by government? How do you raise that there's a change in circumstances and that perhaps a new approach is needed? How does that work?
So we keep a watching brief on issues such as drug-related deaths, crime survey data on prevalence, issues such as treatment presentations. So we have a way of keeping an eye, as what's described in the Act as a watching brief on drug harms. So that's how we do it. And
you'll wait until fentanyl's in the country, people are dying, and then you will say we need to do something?
Well, not at all. As you will have seen, we've written a report on fentanyls with a number of recommendations, really highlighting just how concerning this is. And in fact, we're working on a further report looking at different synthetic opioids. So one of our roles is to absolutely get ahead of the harm and look at the evidence and explain what that might be to government. We've seen enormous harm from fentanyls and fentanyl analogues in North America, and it's a great concern that could come here.
Okay.
Our report is written very much in the way of prompting government to think about these issues in advance.
Have they accepted the recommendations that you've made to them?
We're still waiting for them to respond.
Sorry, this was 2020 you wrote the report and gave it to government. And it's now 2022. You're waiting for a response. Okay, thank you. Diane Abbott.
I was very interested to hear you say that reviewing cannabis is not a priority for you. I think the public might be amazed. It's 14 years since you last looked at it. And the point about cannabis, as we heard earlier, is it's a gateway drug in a particular sense, that the dealer you get your cannabis from may be the same dealer you get your opioids from, or other, as it were, more harmful drugs. Are you confident that you can justify not looking at cannabis, not regarding it as a priority? Do you really think you can justify that?
So just to clarify, we're not saying it's not a priority.
A priority for you.
What we're saying, there are many, many priorities, and we have to work out which we're going to do first.
I understand that, but it is the most commonly used controlled drug, and whether physiologically or in trading terms, is a gateway drug to opioids, and yet public money is being spent on an advisory council that does not consider reviewing cannabis. After 14 years, it's been 14 years since you last looked at it, public money is being spent on a council that doesn't regard reviewing cannabis as a priority. That's what you're telling me.
So just to respond to that, I mean, the majority of our commissions come from government, and so we've not been commissioned by government to look at that. So that is an important point, because, typically, if something's a priority for government, they will be asking us to do it.
Yeah, but you did say that not all of your commissions come from government. So you could choose to look at cannabis if you considered it a priority.
We could, and as I say, we do have a process for each year looking at what we think are the key things that we need to focus on. And other things have come before a review of cannabis. And that's the situation. We focus on drug-related deaths because we feel that is the most urgent issue for us to be looking at.
Parents might also consider it urgent to look at the use of cannabis, because so often their children go on from using cannabis to accessing more serious drugs. But I'll leave you with your assertion that it's not a priority. As you'll know, in 2021, the Information Commissioner upheld the Home Office's decision to refuse a publication of your 2016 report, in which I understand you recommended the decriminalisation of drug possession for personal use. Is it the case that you did recommend that in your 2016 report?
So that's not the case. We have a variety of internal discussions, which is only healthy in a council such as ours, and we produced our final report, which was looking at the interaction between the PSA, the Psychoactive Substance Act, and the Misuse of Drugs Act, and that's published on our website.
Do you think the Home Office's decision not to publish the 2016 report is conducive to fostering a practice of transparent policy making?
Well, I'm glad you asked about transparency, because this is a very important issue to me.
Yeah, that's why
I think it's absolutely critical that people can look at the recommendations we make and understand how we've made them. And that's why we've published in detail how we collect, analyse and produce our recommendations. That's why we've been so clear about putting out our health and social harms matrices. You can see exactly the metrics that we're looking at to try and reach a conclusion. And that's why we published a summary of how we reach scheduling decisions, so that it's very, very clear to people how we're reaching those conclusions.
Okay, finally, can I put this to Dr. Finch? Because I note that you have responsibility for addiction services across Lambeth, Bexley, Greenwich and Wandsworth. To what extent does your practical experience of addiction services confirm your view that cannabis is not a priority?
In addiction services, it very much confirms my view, because addiction services, they are mainly people who present for treatment are mainly opioid users, and the ACMD's looked at that in a lot of detail, because we looked at things like opiate substitution treatment, other issues to prevent drug-related deaths, such as using naloxone. So they're very relevant to current treatment. I think the ACMD haven't looked at where and how cannabis users can present, but they tend to be a different group, and so we've looked at them very separately, and done various reports about what would be the most effective treatments.
Okay, finally, Chair, in your capacity as someone that's responsible for addiction services in Lambeth, Bexley, Greenwich and Wandsworth, are you saying to me you've not looked at how cannabis users present?
I am here in my capacity as chair of the Recovery Committee at the ACMD.
Yeah, but we know you have other roles.
I do.
I'm saying, in those other roles, are you saying that you have not looked at how cannabis users present?
I don't think it's fair to comment on my other roles.
Okay.
Okay, can I just go back to the point that Diane Abbott raised about the report that was produced in 2016, where I think it was reportedly that the ACMD recommended the decriminalisation of drug possession for personal use. I just wondered whether you could just say what is the current position of the ACMD on that point then? Are you able to say that?
Can you ask that again? I'm not quite sure I understand.
So my understanding is that the report that was produced, it's reported that, because it's not been published, we don't know, but it's been reported that the recommendation was to decriminalise drug possession for personal use. But we don't know what was in that report, but what I'm asking you as the chair of the ACMD today is what is the position? Is that what the ACMD is saying should happen?
Do you mean under the Misuse of Drugs Act or under the Psychoactive Substance Act?
Well, I haven't seen the report, so I don't know particularly what was in that report, but what is the position of the committee today?
The discussion was really around temporary drug class orders, or TCDOs, as they're known, and the question was really whether these should be retained or not. And so this internal discussion was really about trying to understand that, where things fitted and how the two acts interfaced. And we came up with recommendations around retaining the TCDO, sorry to use technical terms, but to retain that within the Misuse of Drugs Act.
So there wasn't a recommendation to have decriminalisation?
No, we've never published, finalised any sort of evidence around that.
It's just unfortunate we've not been able to see the full report, because obviously it's seen that that's what you were, or the reports were, that's what was in the report that you put out. Anyway,
just to be clear, all of our final conclusions are published. So anything that we reach agreement with as a council is published. There will, of course, be internal discussions, and that's right and proper that we can test out different ideas. But all of our final recommendations are available on our website.
But the Home Office decided to refuse the publication of the 2016 report. That's correct, isn't it?
I'm not sure that is correct in the sense that I don't think that is that's not a published ACMD position. It may be an internal document, a discussion paper.
Okay, perhaps we'll get clarification of exactly what it was that wasn't published. Can I just ask you one other question, which is there's been quite a lot of criticism about the provision of cannabis-based products for medicinal use as being restrictive. I just wondered, what do you say about that? Do you agree with that?
So this is a complex area, and I think the way to frame this is to be clear about the two broad types of products that are available. So the first product or group of products available are licensed cannabis-based medicines. So these are medicines that the companies that make them have submitted them for market authorization. One is called Sativex and is in Schedule 4, and one is called Epidiolex and is in Schedule 5. To be clear about them, any doctor can prescribe them. They are approved for certain conditions by NICE, which is the sort of gold standard which many clinicians look towards. And we think about 800 people a year are in receipt of one of these licensed cannabis medicines. The second group are unlicensed cannabis-based products for medicinal use. Now, these are products that the manufacturers have chosen not to apply for market authorization through the normal regulatory framework. They lie in Schedule 2 because there's less clarity around their safety, around their efficacy, and about their content. And we've made a number of reports over the last couple of years about how these products could be more helpfully introduced into the health system. As it stands, this second group can only be prescribed by specialists on the GMC, on the General Medical Council register, and they are not supported by NICE at the moment. Although, as we've talked about reviewing evidence, I mean, these things do get reviewed.
And there aren't any under that section?
I'm sorry?
Sorry, there aren't any that are being used under that second category?
So there are very few prescriptions in the NHS. There are more prescriptions, I understand, in the private sector. The data is quite hard to get hold of. And we, in 2019, produced a report summarising the impact of the rescheduling. And in fact, sort of coming back to the point about reviewing things, we're actually coming back to look at this again because we feel that the data may have changed over time.
Okay, thank you very much. We are very short of time, so I'm just going to take Stuart MacDonald and then we'll conclude.
Thanks very much. It's a big topic, but obviously not enough time to cover it in depth. But we touched upon, or you touched upon, harm reduction measures, and in particular use of naloxone. I think opiate substitute treatment was also mentioned. Is it your view that this country is doing enough of that and offering enough of that type of treatment? And could also mention drugs testing and drug consumption rooms as possibilities as well?
So quite a lot there to cover quickly. Again, as a scientific advisory council, our job is to look at the evidence and look really to see where the science says things work. And so we've got very, very strong evidence that opioid substitution is a highly effective treatment. We've got good evidence showing that naloxone is an important thing to provide. We've made recommendations around drug consumption rooms. And so that's the point we say, this is what the science says. We put those in recommendations and we hand it to government then to decide what to do with those.
And briefly, what was, in summary, were your recommendations in relation to drug consumption rooms?
I'm sorry?
Well, in summary, were your recommendations in relation to drug consumption rooms?
So we made a recommendation that there should be a pilot of a drug consumption room in an area of high injecting prevalence.
When did you make that recommendation?
That was made in 2016 as part of our drug-related deaths report.
Okay. Very, very, very quickly, because we do have to go to PMQs.
You feel ignored by government?
Not at all. We receive an enormous number of commissions from government, some of them often very urgent, and so the government gives us a lot of work to do. So we
recommendations.
don't, if I might finish, so we don't feel ignored. There's, of course, situations where we will make recommendations, and as you say, that they may not be accepted. But I think it's about coming back to understanding what the purpose of the council is. Okay. We're a scientific advisory council. Our job is not to write policy. Our job is to provide government with the science. It is government's job then to decide what to do with that.
I think we're very clear on that. Thank you very much for your time today. If there are any questions we haven't been able to put to you, we might write a letter to you just asking for some further clarification. But thank you so much for your time. Thank you.
The proceeding has ended.